Welcome back for our Hernia A to Z fundamentals. Today's lecture is about hernia prevention or optional surgical techniques to minimize hernia occurrence. I'll call hernia prevention. Again, our disclosure of BDI with Hernia U. Everything that we do here is sponsored by BDI, and we need to disclose it every time. It's never enough. What I'm going to go over today are mainly primary prevention and secondary prevention, mostly primary prevention with two big topics: proper abdominal wall closure and use or not a prophylactic mesh. I think that phrase from Franklin is very adequate right now for our lecture. Is an ounce of prevention is worth a pound of cure. Absolutely, it's cheaper to prevent than to treat, and it's a lot better to our patients if we prevent rather we treat them. What we know right now that surgery has evolved tons. We have a huge evolutions in different fields of surgery, but we still have wound complications, a big challenge in our day by day as surgeons. And morbidity increases a lot of cost and gets a lot of pain to our patients. We know right now that we have up to 20, even more incidents of incisional hernias in specific groups of patients, and surgical site infections up to 1/5 of our patients. And once imagine that we could have this reduced by low numbers, but we are evolving different areas of surgery, but we are not evolving in this abdominal wound management as good as we are doing with different categories of surgical complications. And why that's happening, and then how can we avoid or how can we decrease those numbers? First step is to understand the healing process. And for me, this is the most important slide of the whole lecture, is we understand how our abdominal wall heals after we open for anything, and then we need to close it. We have this graph showing the strength of the abdominal wall comparing to the original virgin abdominal wall strength and the time here on the horizontal. So once we close the abdominal wall, we have different phases. The first phase is the inflammatory phase, and we have a very weak abdominal wall, and then we start the proliferative phase when we have a lot of deposition of collagen and remodeling, and then we have the final remodeling phase that can take months, even years to finalize. What you have to understand from that white line is that we never reach 100%, never. If you have a full healed abdominal wall, we'll have up to 70-75% of the original strength. So every time we make incision in abdominal, that point, that location will be a weak area. If in the best scenario, you have like 70 or 75% of the original strength. That's point number one. Point number two, we have the first 4 weeks or the first month, a very weak abdominal wall, below 50% of the original strength, even below 30 or 40% of the original strength. This is the inflammatory phase. That's where we need the aid of the sutures or even the mesh to prevent a hernia or to prevent a evisceration. And then we start the proliferative phase as where we gain strength on the abdominal wall healing. The second point here is that we can have some local factors that will change that curve. We shift to the right. We delay the normal process of healing. It can be infection, for example, is the biggest example of delayed wound healing. So if we delay, we shift to the right this curve, we can take more time to reach the same strength. So perhaps we need more aid of suture and perhaps mesh. What happens when we have dehiscence of the abdominal wall fascia? Every time we reoperate open abdomen, dehiscence and evisceration, usually we see intact sutures. It's the tissue that breaks. It's not the suture that breaks. Almost 80% of the times, the tissue is weak for some reason and breaks and ruptures, not the suture itself. It's what we notice most of separation. So what can we do to modify this weakness of the tissue? The first point is, how do we close the abdominal wall? And there is some evidence that we should close in a continuous pattern instead of interrupted pattern. When I was trained a lot of years ago, there's some old professor that taught me to do interrupted, and they didn't like continuous because they say, oh, if the suture breaks, you'll have the full open abdominal wall. If I have interrupted sutures, if breaks one, we still have the others. Okay, I can understand that rationale, but the point is, with interrupted suture, I don't distribute the tension through the full incision. If I have a continuous suture, I can distribute the force through the full incision. That's the difference. That's what makes different in the results. That's why it seems that in that meta-analysis over 1,700 patients, continuous suture has less occurrence of incisional hernia than interrupted sutures. So we should not use interrupted sutures. We should use continuous suture. And there's another theory besides only the tension distribution. If you go back to mathematics, and this is a triangle, and we know that this geometric sum is always the same. So if we stretch the abdominal wall, we are going to stretch the suture, and we are going to hold more the tissue together, because we increase this and we need to shorten this to keep the same equation true. So that's why Pythagoras theorem helps us to understand why continuous suture is good for abdominal wall. One, because we distribute the tension, and second, because we tend to make it tighter when we stretch the line of suturing. The second point is, we should close plane by plane or just one mesh closure. And what I mean with mesh closure is not like skin, subcutaneous, fascia, peritoneal all together. No, it's not that like this. It's only the facial plane. We don't need to close peritoneal, posterior sheath, muscle, anterior sheath. Just one facial closure. It showed us, it showed that the mesh closure has less infection than layer closure, and less hernias than layer closure, and less dehiscence of layer closure. Usually because you lead for less ischemia of the wound when you close just one layer than we close a lot of different layers. So continuous suture, and second, only one plane, on one facial plane. Another topic that we've been hearing a lot from the last 3 to 4 years is the famous 4-to-1 pattern. What is this? What does that mean? This ratio 4-to-1 is the ratio of how much suture we need to use compared of the length of the incision. So we take the length of the incision multiplied by 4, and that is the length of the suture that we should use. So how do we know how much suture do we use? Usually we have the length of the suture on the package. We have to discount the length of the suture that we did not use, the initial thread knot, the final thread knot, and those threads we haven't used, and we discount this from the original, and now we know exactly what we use. For example, this rubber pad has 8.5 centimeter length. Here to here is 8.5. Okay? So to close 8.5 centimeters, I need 4-to-1, 34 centimeters. I use one suture that has 70 centimeters. I did the first knot. I lost 6.5 centimeters. I did the continuous suture. At the end, I have a second knot, and I lost more 12.5 centimeters. So this plus this, I haven't used 19 centimeters. So if the initial suture have 70, I haven't used 19, I did use 51. So if I needed to use 34, I'm good. I did a good job. I have a higher ratio than 4:1. It seems that higher ratio does not improve. So I don't need to do 5 or 6:1, at least 4:1. A little bit more, it's okay. A little bit less is not okay. So that's the way that we measure how much suture length we use when we are closing incision, abdominal incision. But what I mean with 4:1 is just one parameter. The other parameter that people sometimes does not, they don't talk too much is about the bite size, spacing and bite size. For example, those 3 sutures, the surgeon used 4:1 ratio. First, second, third, in all examples, the surgeon used the same amount of suturing. But this is a small bite, a small size, and this is a big bite and a big spacing. So a small bite is how much of the tissue you grab between the suture and the midline, the opening, and the spacing is in between sutures. So here I did 21 passes of the suture. Here I did 16, and here I did only 11. To use the same amount of suture in 11 passes, I have to use wider bites. So that's the way that I use the same amount of suture. But it's clear that here we have best tissue strength than here, and I'll show you why. But we have to remember that ratio 4:1 is just one aspect of the proper technique. The first aspect is small bite and is small spacing. Small bite, small spacing is less than 5 millimeters, around 5 millimeters. We don't want 3 or 2 millimeter bites, at least 5 to 8, and 5 to 8 spacing between them. So this is what the experimental paper show us, that when you suture flesh with bigger bites or smaller bites, you have more strength here than here. And a comparison that I do is always with the notebooks. You can take a binder and 100 pages and put a 3-hole binder, and you can put that hole in the middle of the page. I don't care. If you hold by one sheet of paper, it will rip and go to the floor, the other 99 pages. But in a notebook, when you have a lot of small bites, can be very close to the edge, and I can hold the same 100 pages by just one sheet of paper, the another 99 will not fall. I will not rip the paper. Even I'm really near to the edge of the paper, but the tension is distributed all the way around the incision. Different than here, the tension is concentrated in only 3 points. So that's a kind of comparison of big bites and small bites in abdominal wall closure. Going back to that curves of abdominal wall strength after closure. So now we learned that we should do small spacing, small bites with 4:1 ratio with a continuous suture and 1-layer closure. We have just learned that. But which suture should we use? We are going to use the rapid absorbable sutures. They lose a lot of tension strength fast. So if they lose the tension strength before 4 weeks, you have a danger here, because you are not yet with a good strong abdominal wall, but you are losing the aid of the suture. And here is interesting that Vicryl is a suture that sometimes, a lot of times is used, and people say, okay, Vicryl lasts for 90 days. That's true, but it's not the time the suture takes to be absorbable, but the time the suture takes to lose tensile strength. And Vicry lost about half of its tensile strength by 1 month, by 4 weeks. And that's what we see here. By 4 weeks, it lost tensile strength, and we don't have yet a good abdominal wall. In silk, about the same. What seems to work is the slowly absorbable suture, as Maxon and PDS, because they are absorbable, but they take longer to lose strength, and that works for us. Because after 4 to 6 weeks, we hope that our abdominal wall has good enough strength to resist without the aid of the suture. And for sure, if you use a non-absorbable suture, you will never lose tensile strength, so you will be there forever. So now we know that we should not use rapidly absorbable, but should we use slowly absorbable or non-absorbable suture? Comparing those two groups, rapid absorbable with non-absorbable or with the low absorbable, we know that we have more incisional hernia with rapidly absorbable. Okay, and no difference between slowly absorbable and non-absorbable. Both seems to work in abdominal closure to prevent incisional hernias. Now, if we compare suture sinus, the granulomas, the chronic granulomas, absolutely we're going to have more granulomas on it with the non-absorbable sutures. And then this can lead to wound pain. The chronic granulomas can lead to wound pain. So that's why when we consider the incisional hernia occurrence, we should use non-absorbable or slowly absorbable. But when we compare those two sutures, that it seems to be more advantage to use slowly absorbable sutures to prevent chronic pain on the wound with chronic granulomas and suture sinus. That's why we tend to use more slowly absorbable suture instead of non-absorbable sutures. And those are the guidelines from the European Hernia Society about the closure of the abdominal wall, saying that continuous sutures with a slowly absorbable monofilament suture in a single layer, doing a small bite techniques with the ratio 4:1. So this is the consensus, the guidelines, and it's just the conclusion of everything I just explained for you for the last 15 minutes. The second topic that I would like to address now is the use or not of prophylactic mesh. So if we know that a group of our population is going to have a higher incidence of incisional hernia, why not to use a prophylactic mesh to avoid the incisional hernia? But the point is, who is that group? Which patient goes to that group? Which risk factors concur to increase the risk of incisional hernias? There's a lot of publication trying to show us which are the risk factors, can be minor or major, and the main ones are obesity, chronic use of steroids, diabetes, smoking, chemo and radiotherapy. Seems that males have a higher incidence of incisional hernias and older people as well. And there are some risk factors that are not from the patient themselves, but from the wound. And those, we know that the midline has more hernias than transverse. I'm not saying that we should not use midline, but we know that as linea alba is a tendon insertion from one side muscle to another side muscle, that's tension, the physiological tension midline. So we have more incisional hernias with longitudinal midline incision than transverse incisions. And as we just discussed, the type of closure and suture used, and we learned how to do a proper abdominal closure in the past 15 minutes. So where and how we should use a preemptive mesh, a prophylactic mesh. The main idea with the mesh is we change the tension from a line, that is the suture line, to an area. We distribute the tension in a larger, a broader area. With that, we should have less dehiscence and less hernias. And that's the idea behind using a prophylactic mesh. But who is in higher risk? And there's some publications, this is from Mexico, if I'm not wrong, that try to create risk criteria to make a score that should predict who should have hernia and then who should have a prophylactic mesh, and trying to create different groups. It's not an easy score to use, and everyone should have their own criteria to decide which patient should use. And they propose that you use a lightweight mesh at least at 5 centimeter wide to avoid. And this is another paper 5 years ago showing that it's clear advantage when in a high risk group you use mesh. There are 7 papers, more than 500 patients analyzed, showing the mesh reduce the incidence of incisional hernia, and we should use mesh in high risk patient. There's another study, not in hernia, but in the World Journal of Surgery, showing 9 studies showing basically the same results, that there is a benefit for use of mesh in a prophylactic situation in patients that are in a high risk group. So, but how should we use that prophylactic mesh? It can be any position, but there's a trend right now to only position, but that's not only the only way that we can use a mesh. Only seems to work. It's easier to use. We don't need to use 10 centimeter wide mesh. It's not for incisional hernia treatment. It's for prophylactic. We need just to create a small subcutaneous pocket to put the mesh. Sometimes not that wide, but just 5 to 7 centimeters. We can use an underlay. Put the underlay mesh in a preperitoneal space or a protected mesh in an interperitoneal space, and just close the fascia on top of it. Well, this publication I read a couple of years ago showing grade A prophylactic mesh should be used in stoma, and grade B in high risk group. The most studied group is the patient with the obese and the ones that are submitted to a AAA repair. Peristomal, you can use a flat mesh, just cut it in a cross, or use specific cone-shaped mesh to avoid. And seems to be really good evidence-based medicine showing us that in permanent stoma we need to use mesh to avoid peristomal hernia. And that's what I'm showing you. This is a 2-year-old paper showing very clearly that if the patient is having a permanent stoma, we should use mesh. And clear advantage when you compare with known stoma patient for hernia, and it seems a little bit more complication, but not statistically significant, the rate of complication when you use mesh. So primary prevention was a good abdominal closure and a use of prophylactic mesh in selected group of patients. Secondary prevention. So what happened? We do have a hernia and we want to operate and we don't want more complication. The answer is easy. It's use mesh. We can spend slides and time talking about it, but it's clear that for incisional hernias, we should use mesh to treatment. So this is my one slide message for secondary prevention in incisional hernia repair. Use mesh. So to wrap up, we should learn how to do a proper abdominal closure, and sometimes we leave this task for a resident and even for a first-year resident that is not properly educated on how to do a proper closure of the abdominal wall. There are some groups that advocate that we have different surgical team for abdominal closure. A fresh team goes inside just to make the closure of the abdomen. I don't know if we need all this, but at least we need to pay attention to the last part of the operation, that is the closure of the abdominal wall. With one plane, continuous, slow absorbable suture, monofilamentor in a small by small spacing 4:1 ratio closure. This is the bottom line message. And remember that in high risk group, Prophylactic mesh should be used. There's no doubt in permanent stoma, but in abdominal wall incisions, if the patient has criteria that meets high-risk patient, we should use a prophylactic mesh to reduce the incidence of incisional hernias. And secondary prevention, I just said, mesh-based repair for incisional hernias in adults. There's no doubt that the mesh reduce the recurrence of incisional hernias in adults. So, thank you for your attention. I will ask you to take the post-lecture quiz, answer our questions, and there will be a space for your questions, your doubts. You can type during or after your quiz, or I invite you to join us in our Q&A live session in a few days, and it will be me, Eduardo, and Salvador on live to answer your questions, the ones that will be made on live and the ones that you do after your quiz answering. Thank you so much.